Thank you for joining. Sorry, Lubna, I forgot to give you the thumbs up. Yes, so thank you for joining us to talk about menopause today. So before we begin, I'd like to acknowledge that we live and work on the traditional territories of many Indigenous nations across Turtle Island. While we meet today on a virtual platform, we must recognize the importance of the land and our treaty agreements. We acknowledge the ancestral and unceded territories of all Inuit, Métis, and First Nations peoples. As our Spinal Cord Injury Ontario community encompasses many geographies, we ask that everyone take a few moments of their day to find out which unceded or treated territories you may live and work on. You can use the link www.native-land.ca to learn more, and I believe Luna will put that in the chat box. So for those of you who don't know me, my name is Julie, and I'm a peer program coordinator in the London region for Spinal Cord Injury Ontario. And I've got two co-hosts with me today. Melanie, who along with her husband Wallace have created the T6 Talk website, and Lubna, who is the manager of our peer program. So there's just a couple of rules of engagement I just want to quickly go through. So all participants will be muted throughout the presentation to cut down on background noise. We are recording this session, so if you do not wish to be seen, please just ensure that your video is turned off. For those willing to appear on screen to ask a question, we will enable your camera permission by asking you to start your video and your audio. If you prefer not to be on camera but would like to ask questions, we will be monitoring the chat feature throughout the presentation. So please feel free to type a question into the chat box. So our guest presenter today is Dr. Cathy Craven, who is a senior scientist as well as a physiatrist for UHN. Followed by Dr. Craven's presentation, we will be joined by three individuals with lived experience who will discuss what their journey has been like with menopause. So Dr. Craven, I will now turn the presentation over to you.
Okay, let me try sharing my screen. Maybe that will work, maybe it won't. Let me just try. Can you see my screen?
Yes.
Okay. All right. So thanks everybody, and I appreciate the invite to talk about this issue. I want to talk a little bit about menstruation and menopause. I know people wanted to focus on menopause today, but I thought it was important to sort of give a little context. And to me, this is really just about getting to know your body over a lifetime. That it's always doing little tricks on you that I think are worth discussing. If you're interested in some of the work that we're doing, you can find our lab website, cravenlab.ca, and happy to connect with anybody on Twitter if they're interested. Many of the things we're going to talk about today are kind of awkward and you may not feel comfortable talking about, and that's okay. So you can feel free to sit awkwardly in silence or to pipe up and chat with one another. I think that it's very important to have a sense of a community and other women that you can talk to about what's happening to your body and try to normalize your experience. So expect to be a little awkward, but I would encourage you to reach out and speak to each other as the session goes on today. I'm hoping, this is a quote from Oprah that I hope you'll take away with you. Menopause is your moment to reinvent yourself after years of focusing on the needs of others. It's your opportunity to get clear about what matters and to pursue that with all of your energy, time, and talent. I apologize for the spelling, but I really would like people to think and reflect about this. How many people are caregivers for somebody else? If you could just raise your hand or show some sort of reaction that you are taking care of yourself or somebody else. A parent, a child, a spouse, a partner, a dog, cat. I see that's true for many people. Many women are strong multitaskers. And one of the things that happens during menopause is that becomes a bit more challenging. And so it's really important as you hit menopause to think and reflect and focus on those things that are really important and meaningful to you. I hope by the end of this session today, we'll have talked a little bit about the signs and symptoms of having a period, or what's called menses. I wanted to talk about amenorrhea and whether you should celebrate it or investigate it, and to talk about menopause, both the victory and the reality for many women, particularly with spinal cord injury. So that's sort of what I was hoping to talk about this afternoon very briefly. I think if you look over the women's lifespan, we spend the first part of our lives getting excited about maturing and becoming a woman and having the capacity for fertility. And early after spinal cord injury, women have usually a short period of amenorrhea when their periods are missing. And then we have what's called the perimenopausal period, which is where your body is preparing to shut down reproduction. Stops releasing an ovary each month, and you may have erratic periods. And then once you get to a period of no period for 12 months, you would get to menopause. And I will revisit these terms, but this is what I mean, getting to know your body over the lifespan, because many of you will have maybe had your period before your spinal cord injury, some of you after. You may have had a period of amenorrhea. Many of you may be living with perimenopause or approaching menopause. So you'll hear different information in this presentation depending on where you're approaching this from across the lifespan. And just want to start a little bit talking about menses, or having your period. And I wonder how many people, when you got your first period, did you celebrate with your family, or did you commiserate with someone about your period? How many people would say they got a chance to celebrate? Any reaction? Thumbs up.
I celebrated quietly.
Quietly, okay. And some people may have had a chance to commiserate because there was somebody else, a sister, a parent, or somebody else who had similar symptoms. So typically your periods after spinal cord injury are really the same in terms of length and duration. And similar to before your spinal cord injury, you'll get similar symptoms of sort of non-specific fatigue, breast tenderness. You may get abdominal cramping or low back discomfort. Many people will report leg swelling or water retention just prior to their period. I apologize for the typo. And most people get what I call Pms acne. They know about 7 to 10 days before their period's coming, because that's usually when they get really nice zit as a forewarning that their period is coming. I don't know how many people are experiencing that now or have had that before. And then when you have a spinal cord injury and you're having your period, this can trigger some other issues that you really need to be aware of. So one is bladder spasms, which can contribute to urinary incontinence and is sometimes mislabeled or thought to represent a UTI, and people are given antibiotics, with their period each month, which really doesn't need to happen. They just need to recognize the bladder spasms and manage them a bit better with medication. And many people with the onset of their period will experience autonomic symptoms. That's typically people with lesions of T6 or above, but has been reported in the literature down to T10 and above. But typically it's people with a lesion above T6 that would experience sweating, flushing, headache, goosebumps associated with PMS. You may also experience autonomic symptoms when you put in or remove a tampon, when a tampon becomes overly full, or if you're actually experiencing a pressure area from a pad that has just become swollen with blood. So I know many of you will have been familiar with autonomic dysfunction. Often with periods, it's a mild grumbling that people report, and not the sort of fulminant autonomic dysreflexia that's an emergency, but what I call dysautonomia, or sort of mild autonomic dysreflexia. But most people can use those symptoms as, hey, I know my period is coming or I need to manage. And people sometimes rely on those autonomic signals to tell them when to change a tampon or a pad.
interrupt for a second, Dr. Craven?
Absolutely.
I have a question with regards, like when you're going through this, I was wondering if, as well, if there's any information you can provide for people who are trans. So trans men who are maybe going through HRT, how does that impact their menstruation, and how might that impact their going through perimenopause and menopause as well? I don't know if you can speak to that.
I can try. So a lot of the symptoms that we experience related to premenopause, related to fluctuations in estradiol and progesterone levels, which are similar in trans as well. People, so you will see some of the similar symptoms. You don't always see the sort of low back pain or some of those other features, but a lot of the breast tenderness, fatigue, the morning acne, you will see those things that are related to the hormonal swings. So I don't know if that helps. Most people, after they have a spinal cord injury and you're managing your bladder with intermittent catheterization or an indwelling catheter, or you're able to avoid spontaneous, there's a long discussion about tampon, cup, pad, what should I do? So in general, I try to encourage women to use tampons. They do need to be changed while you're sitting up in your wheelchair, or change after transferring to bed. And I know a lot of women worry and ask me about, do I have to worry about the tampon falling out during a transfer? And that's only usually a problem if it's become overfull and is starting to make its way out. And for those of you who do have autonomic dysfunction, you will need to change the tampon a bit more frequently than an able-bodied peer in order to avoid autonomic dysfunction. And if you are using a tampon, it will make the intermittent catheterization process a bit cleaner than if you're using a pad, because then you have to spend quite a bit more time cleaning the perineal area before doing the catheterization. And anecdotally, many women tell me they have less bladder infections if they're using a tampon versus a pad, but I'm happy to hear about the experiences from those in the group. And recently there's been a lot of use of the Menstrual Cup, which is a really great tool if you are confident that you have sufficient hand function to put it in the place yourself, or you have an attendant or partner you really trust to make sure that it's really in the right place. But a lot of people find it challenging if you're trying to catheterize from your chair multiple times a day. But for women who get menorrhagia, that's very heavy periods, which often happens in the perimenopausal period. These can be very helpful, but you have to be very vigilant about, is it placed appropriately, and removing it with sufficient time so you're not leaving it in overly long. And I think what a lot of family doctors and physiatrists don't remember is that sometimes we need to prevent AD. This says after fracture, but it really means after your period. So you'll find that there's many women who just routinely get mild to moderate AD with their period each month. And there is a group of women that just providing analgesia or medications to cause the uterus to relax can really change the experience of having a period after spinal cord injury. And so I think some people fail to do that. They think, oh, you have a period, you don't have sensation, you don't need anything. And for many people, though they don't experience touch on the surface of their skin, they still have intact visceral sensation, and so do need medication to prevent autonomic dysreflexia associated with menses. And the other thing I want to raise is that there are some reasons when your periods are abnormal that you really do need to see your family doctor, a gynecologist, an endocrinologist, or a physiatrist for a full assessment. And these should be things that you are doing it more urgently, not just when I have time, but you really make a point of going in and being seen right away. So if your periods are becoming very heavy or come with a large number of blood clots, that warrants evaluation, and also to consider whether you might be a candidate for uterine ablation. And if your periods are lasting many more days than usual, if you spot or bleed after your period for a prolonged time, or if you have spotting after sex, or your periods occur closer together, that can happen with what is called oligomenorrhea, or if they actually disappear altogether. And I apologize for the number of typos that I have today. So what do I mean by amenorrhea? So amenorrhea is when you have a period of time that your period is absent. And there's two types of amenorrhea. There's primary, where you, as a young person, may never had the onset of your period, which usually is due to a problem in the pituitary axis, or at the uterine level. And then there's secondary amenorrhea, which is what most women with spinal cord injury experience. And it's, in most cases after spinal cord injury, is temporary and not permanent. About 50% of women miss their period early after their spinal cord injury due to a combination of their neurochemical response to stress, a transient elevation in prolactin. And there's a small group of people who would have had primary amenorrhea, never had a period before they had their spinal cord injury onset. And typically early after injury, it takes about 3 to 6 months before your periods return. But in some women, it can be up to 30 months. But if it gets to be 6 months or more, that's the time that you really need a gynecology consultation. So that's amenorrhea. And there are some very simple investigations for amenorrhea that can be initiated by your family doctor or physiatrist before you even see a gynecologist. And that's really taking a very detailed dietary, medical, and menstrual history, measuring your FSH and LH, your prolactin and estradiol levels, and before they refer you to endocrinology or gynecology, and also trying to rule out whether you have an eating disorder or you might have polycystic ovary syndrome, which is where you have amenorrhea associated with cardiometabolic risk. And there seems to be that PCOS seems to be a bit more common in women with spina bifida than with other forms of spinal cord injury, but that's just my own clinical observation. That's not actually reported in the literature. And then, of course, there is menopause, when your hormones are raging and you get lots of behavioral changes associated with changing and loss of your periods. So menopausal symptoms, this is the most frequent ones that are reported among women with spinal cord injury. So menstrual cycle changes, sleep disturbance, which really interferes with people's ability to just cope with life on a regular day, and the presence of night sweats. And I know most of you, when you wake up in the middle of the night sweating, will think, am I autonomic? Am I getting a bladder infection? Could I have a chest infection? Am I developing a syrinx? Could I have a blood clot? So when women first start developing night sweats related to menopause, it often requires a medical evaluation and sort of teasing out, is this night sweats related to hormonal changes, or do I have something else going on medically? So in some people, the first appearance of syringomyelia can be just nighttime sweating or an Charcot joint before you actually see any changes in function. And you can sometimes see night sweats just with a blood clot. So it is really important when you have that onset of menopausal symptoms that you actually see your family doctor, physiatrist, and have that evaluation done.
Dr. Craven, can I interrupt you again?
Absolutely.
Anita has her hand raised.
Sure, Anita, go ahead.
Hi, Dr. Craven. Just going back to the slide that you're just on, I'm curious with those percentages that are being provided, is there a distinct difference between individuals who are quadriplegic, or let's say T6 and above, versus below, or those with complete or incomplete injury in experiencing?
Yeah, so this is data. Yeah, this is a paper from Susie Charlefew from 2004, Anita, and they mostly looked at people T6 and above, so an important context. Yeah. Thanks for the question. I think I must have opened a draft version of my presentation and not the final one, because we're seeing all these typos and no reference. So I apologize. I will circulate the final version, and I apologize. So the other thing I wanted to talk about is if you look at menopausal symptoms in all women, and I wanted to talk about how some of them affect women with spinal cord injury specifically. So we just talked a little bit about night sweats or the chills, but I did want to talk about thinning of the hair and skin and vaginal dryness, which I think are really specific threats to women with spinal cord injury and really need a sort of a concerted efforts to address for people. Particularly in terms of your skin health, you want to make sure you have that moisture balance and good hydration. So this Eucerin Aquaphor product is a really great one for helping to sort of restore the moisture balance in your skin after menopause, and making sure that you're well hydrated. You don't want to be overhydrated, but that you're well hydrated, and that's, you know, as you would have done before menopause, but your body's a little less forgiving if you're getting dehydrated. You also need to remember, if you're going out in the sun, to apply sunscreen, and you really need to check your perineal region for microtrauma, particularly due to changes in your transfers or after sex, as many women will find they have a lot of vaginal dryness and actually need a lubricant for intercourse concurrent with the onset of menopause. So there needs to be a little bit more checking and a little bit more advanced preparation. So for a lot of people, that's, you know, just incorporating the application of the Eucerin ointment on your skin throughout your whole body, you know, once a day, and then doing those very detailed perineal checks, particularly if you're having changes in your transfers or after sex, because you can get just a small regional trauma, so like the labia during a transfer, or a very small micro trauma from sex because of a lack of lubrication that then opens up and becomes a very big wound. And so these little things can really make a big difference in terms of your relationship and staying sexually active, but not getting into adverse effects of menopause. So just wanted to talk about that a little bit. And then many people struggle with the thinning hair, your nails getting a bit thinner and going away, and some weight gain and slowed metabolism that really does require attention. If you are gaining weight, it does make some of those transfers and things a bit more challenging and can really affect a person's mobility and community participation. So you may not have paid attention to your weight too much before you hit menopause, but you will need to pay attention to it a little bit more. And the sleep problem, the problems with both falling asleep and staying asleep that are associated with menopause, can really be problematic and really does, you know, require a concerted effort in terms of your sleep hygiene and making sure that you are prepared to try to have a restful sleep each night. And for a lot of women who are multitasking, this is an important thing to, you know, stop and give yourself time each night to prepare for going to bed, to make sure that you actually have a chance at falling asleep and staying asleep as long as you can before you're woken by night sweats or other vasomotor symptoms. And then I also wanted to talk about some of the issues related to having fatigue, autonomic dysregulation associated with menopause, vaginal dryness, and some of the pain and bleeding that can come. This can result for some people in sexual dysfunction and even relationship dysfunction. And it really is worth, you know, talking to someone about before it sort of gets away on you. And some people don't realize it's happened, and it's sort of when they look back, they say, oh yeah, I can sort of see this happening, that I've been really tired, I'm not sleeping well, so I'm not interested in sex or a relationship. That you can address these things if you're addressing your menopausal symptoms. And the other thing I wanted to talk about, I mean, there's lots of things in the lay press about mood swings and irritability associated with menopause. But in particular, mood disorders are very common in women with spinal cord injury. They're much more common than in the general population. 50% of menopausal women report increased emotional lability, where you're sweet and pleasant 1 minute and irritated the next, as well as higher rates of depression and anxiety than in the general population. And these are things we can certainly treat. And there are a number of medications that have reduced depression and anxiety, and also reduce the frequency and severity of hot flashes. So there's lots of opportunity to address both your symptoms and the changes in your mood with some of the interventions that we have for menopausal symptoms.
Dr. Craven,
Dr.
we have
Craven.
another question.
Yeah.
Lisa?
Do you have any reasoning behind why we would be experiencing more emotional like variability than maybe an able-bodied person? Because I am autistic, and so going through menopause has had its own art
Challenges.
to it. But also I realize I have a spinal cord injury, and so to see that, I'm like, oh my God, why? Why?
Well, so I think, anxiety and depression go up and down over a person's lifetime. In general, in the spinal cord injury population, mood disorders are a bit more common than they are in the general population. So I think there's a little piece of that. And I think for a lot of women, at least my observation in clinic, is that when people start, their sleep quality starts to go down, just their general ability to cope when they are challenged goes down. So I've not seen any studies that really report like the etiology, but those are the things I know just from looking at aging with a spinal cord injury in my research and, 23 years of doing clinic and talking to women. But yeah, it's interesting. And there's such little literature on this topic. I have to say it's embarrassing. And I have tried through our National SCI conference and some things to really talk about all of the unmet needs of women and related to women's health. But this is a big one. Was a systematic review, like where they amalgamated a bunch of literature, but we can really see that emotional lability, depression, anxiety are more common. And from what we do know, we think the treatment strategies are similar to whether you had menopause or not. So there's lots of treatment available. And of course, if you have comorbid conditions, then that, makes it a little bit more complicated and might be something you would monitor a bit more closely with, a trusted colleague or your family doctor or someone who you trust as you're sort of moving through menopause. And then the other
sorry, Dr. Craven, there's another question. Margaret's got her hand up.
Okay, sure, Margaret.
Yeah, I'm just wondering if it has anything to do with higher cortisol levels experienced on a prolonged basis by women with spinal cord injury. When you see data over time.
Yeah, I would like to say that, but if you look at all the literature, I mean, women with spinal cord injury have global increases in inflammation in every tissue, right? Like high CRP abnormalities in IL-1, 6, and 10 in TNF alpha. There's lots of literature to say that inflammation is the big bandit in this process, but cortisol doesn't explain the whole thing.
Fair enough.
We have associated with metabolic syndrome, which we see much higher rates of metabolic syndrome in women and men aging with spinal cord injury compared to the general population. And we see that inflammatory stress globally is much higher. So I don't think we can point it to one axis, but I think it's a very good point that it is a contributor.
Yeah, and as a layperson, I'm using one term to probably talk about an inability to cope with many stressors over time.
Yeah, so particularly inflammatory stress throughout all the tissues that causes, muscle to break down and fat to be deposited is going on throughout a person's lifetime. Yeah. And I guess the other thing, once people have gotten through that perimenopausal period, they've survived menopause, then we see higher rates of heart disease and osteoporosis. And at that time, you really need to be, you know, as you hit perimenopause, to be engaging with a healthcare practitioner if you haven't already, into the annual serum screening, bone density testing, diet and lifestyle modification, and really working hard to try to maintain your bone mass, because you will have had your spinal cord related bone loss, then you have your menopause, and then you'll have the 30% decline in your bone mass related to menopause that we want to try to turn off well before it starts. And most bone loss is happening in the perimenopausal period. And for those of you who know me, I'm pretty aggressive about treating perimenopausal women with osteoporosis early to try to reduce the risk of fracture downstream. We just released earlier this week a new PVA guideline looking at the recognition and management of osteoporosis for people with spinal cord injury that's available on the PVA website. And the other thing I wanted to talk about, you know, as you reach 50, statistically, most women will go into menopause between the ages of 50 and 52, and some women with spinal cord injury much younger. That's the time in which you need to make sure you're doing that annual pelvic and breast exam. And I personally am very worried about the number of people who have not had routine screening during the pandemic.
Can I interrupt there for the quick question, Dr. Craven?
Absolutely.
I think a lot of the conversations that Julie and I have been having with different people is the fact that they're not able to access pelvic exams because the tables are not accessible. So you have people who have never had a pelvic exam because they can't, you know, they go to their gynecologist and there's not a table that they can get on.
Yeah, so in the absence of a pelvic exam, I mean, your family doctor could do an ultrasound as an alternate. Doesn't do the HPV screening, but it will look for, you know, ovarian cancer or other things. And, you know, we have the new disability standards coming in, and I think it's time that we have to sort of say, not okay, and let's get this fixed. And I actually put this slide in. So thanks for the great segue to, you know, where we want to be is that, you know, I know getting to an appointment is super challenging, and during the pandemic, it's extra complicated. And then that whole, can I actually get in the door, and are there high-low tables? With the new accessibility standards, you know, there is going to be, there's the launch of the standards that happened in January, but in 2023, there will start to be processes to assess whether organizations are actually adhering to those accessibility standards. And there will be, you know, an assessment. And if people are not meeting those standards, they'll be challenged to do so in a timely manner. So I'm hoping this issue of, can I get to a high-low table and can I get somewhere where someone can transfer me, is hopefully going to go away. Not immediately, but maybe over the next 3 to 5 years. So I, you know, I'd really encourage you to still think about, particularly when you hit 50, that you're adhering to those regular mammogram and pelvic exam screening. And I wonder how many people are part of the Ontario breast cancer screening program and get their reminders for that. Is there anybody online who is part of that? Because I have had a couple of clients or patients who were in that program, and then when they couldn't serve the patient, they actually worked to direct them to a center where they could be served appropriately. The other thing,
Dr. Craven, sorry,
yeah,
there's one question from Samantha.
Okay, sorry, Samantha.
No, sorry, I just had my hand up now. I can't get it down. It's all good.
Oh, okay.
All right, if you, yeah. So one of the things that when you reach menopause and at the age of, or just perimenopause around the age of 50, there are a number of guidelines that look at osteoporosis, like bone health, that look at cardiometabolic health, looking at your diabetes and heart disease risk, and looking at your cancer risk. And you really need to know, am I a low, moderate, or high risk person? And part of that is knowing your personal and family medical history and whatever risk factors you have. And so, you know, you kind of need an assessment for each of these things, like your heart disease risk, your osteoporosis risk, and your cancer risk. So you kind of need to think that, you know, between the ages of 50 and 52, you need to be seeing your family doctor a bit more often and having a conversation about these things. And also with your physiatrist to start to have a dialogue about, am I being assessed? What is my risk and how frequently do I need to be followed up? So the other thing, many women aging with a spinal cord injury and after menopause continue to have problems with their bladder, with incontinence, with UTIs, with changes in renal function, kidney stones, and for those with an indwelling catheter, an increased risk of bladder cancer. So not to add to the issues, but it is something that you have to kind of pay attention to, and particularly if you suddenly change your bladder management strategy, you really need to think about the issues we talked about skin integrity. Some women as they age elect to go to, rather than intermittent catheterization, to go to an indwelling catheter. Then you run the risk of having the labia break down or having regional trauma from sitting on the catheter. So we need to treat you as a whole person and not just look at one issue, but try to look at all of your global issues together. And I guess the other thing I wanted to talk about is quite a bit published about social networks, and that people with spinal cord injury tend to have a little bit smaller social network, but the bonds within that network are usually tighter, meaning you have much stronger ties to the people in your network. So I would encourage you to really, in venues like today, or even with the people who you identify in your social network, to reach out and to talk to them. And a lot of these issues, if you talk to other women, you know, who've just been through menopause or who are having perimenopausal symptoms, they will endorse similar experiences. And there's tons of apps and lifestyle behavior things and pearls of wisdom you can get from friends and colleagues about how to cope with this, that you don't need to feel alone and like you're the only one who knows this or has interest in the area. So, and we certainly have Sandra Mills, our patient family educator at UHN, has been working to develop some better materials for women in terms of educational materials that will be available through Spinal Cord Essentials. So, you know, feel free to reach out, but I encourage you to talk to the people around you. You'll be surprised how common the experiences are you're having. So we've been talking about menses and menstruation across the lifespan. I thought this photo is just perfect. The first one is, you know, have I got my period? When is it coming? Repeatedly looking for it. The second one is, oh my goodness, I've got my period, and am I leaking? Do I need to worry about it? And also some of the questions that come related to your period, and am I pregnant or not? And do I want my period to come, yes or no? And then finally you get to hit menopause and life is good. So I'd like you to try to take that sort of thought away and think about menopause as a positive transition across the lifespan, recognizing though that it is a challenging one. Okay, thanks. And I'm sorry, I'm way over time.
That's okay, Dr. Craven. We've got a couple of hands up. So Julie, go ahead with your question.
Just wondering about bone density analysis. I've been referred to my local hospital to have my bone density tested, and I'm just wondering if there's a difference between the information that they can collect at my local hospital versus what would have been collected when I went to Lyndhurst to have my bone density done.
Mm-hmm. If you go get your bone density done at a regular lab, they will measure the bone density of your spine and your hip. And if you come to Lyndhurst, they will, and some other centers across Canada, they'll measure your spine, your hip, and your knee region. Most women and most men with spinal cord injury develop osteoporosis of their hip and knee region. So we can measure your spine and it'll look normal. It's not very helpful. And so measuring the hip and knee region is really the recommendation, because that's where the changes in bone typically occur after spinal cord injury. So you sort of get greater specificity with the testing done at Lyndhurst, but it has to be feasible for you. Like, we do get a hip measure from a regional center, so it's better than nothing, but sometimes you can measure the hip and it's relatively normal, but the knee is very abnormal. So Lyndhurst provides the more sites to get a better perspective. But to me, the most important thing is you go to the same lab repeatedly over time and you can track what's happening over time.
Okay, thank you.
Thanks, Julie. Lubna, go ahead.
So Dr. Craven, if you have one of those IUDs like the Mirena that sort of impacts your periods, how would you know then if you haven't had your period in a long time, what stage of menopause are you in? Because it is obviously induced by your IUD.
Yeah, so then in that case, you just need to have a blood test to sort of see where you're at hormonally. Yeah, I didn't talk about IUDs, but it's a really great point. A lot of women are using them, and that reduces the buildup in the lining of the uterus, and you don't get the periods in the same way. So yeah, you won't know. You might experience some of the other perimenopausal symptoms like irritability or fatigue, but you can arrange to have the blood test to actually check. So it's just a simple FSH, LH, and the estradiol level, and then we can sort of see where people are at.
Thank you.
Okay, go ahead, BP, with your question. Sorry, I'm not sure your name. I just need the initials BP. If you want to go ahead.
Muted.
Thanks, Lubna.
Maybe they can't unmute or something.
Oh, there we go.
Thank you for your presentation, Dr. Craven. I was just wondering, you mentioned that spasticity during menstruation can change. Is that the same for menopausal women? Does it change after menopause?
Well, you don't get the cyclical variation in spasticity that you would associate it with your periods.
Okay.
You know, so when you would sometimes for people, middle schmerz, or when you actually release the egg from the ovary, or you know, when you get abdominal bloating, will be a nauseous stimuli that does trigger spasticity. So often the spasticity will, that variation that comes with your period will go away.
Okay. Okay. Great. Thank you.
Yeah.
Margaret, go ahead with your question.
Thank you. So let me put this into context. My question is around hysterectomy, and only because I've been treating or dealing with heavy periods over the last 2.5 years. I've been in perimenopause for 7 years, and the bleeding got bad enough that my hemoglobin dropped dangerously low, and I ended up having blood transfusion. And. So the first thing we did was watchful waiting, which was a complete and utter disaster. And so after that, we did all kinds of trying to make adjustments to hormones. Last year, put in Mirena, and I've continued to bleed still for about 400 days now. I additionally have 2 small fibroids. And so my last 2 options before hysterectomy are uterine embolization.
Yeah.
We're going to try the embolization first, I think. But I'm also hoping that ablation I will be a candidate for it. I don't know whether I won't be, but my question is around for women with spinal cord injury, are the risks associated with a hysterectomy any different than in the able-bodied population from what you've seen?
That's a really good question. I don't actually know any literature about this. I can sort of tell you some anecdotal stories. So personally, if you can avoid hysterectomy, I would encourage you to.
Thank you.
Because we get a lot of changes in the pelvic floor with atrophy and aging with spinal cord injury. And the more we perturb the anatomical structures, the more challenges there are.
Thank you.
However, endometrial ablation, endometrial embolization is not universally available. And the people who are good at it, you need somebody who has a lot of experience, who's doing it regularly and knows how to manage the anesthesia for someone with spinal cord injury. So it's a great option in hands of somebody skilled. So it's, you know, you don't want somebody who just does it rarely. You want someone who is doing it routinely and has a lot of skill, because there is the risk of damage when they're doing it. You know, same as there's risk. There are people who do need hysterectomy, and sometimes when they go in to do hysterectomy, they find other things they didn't know that the person had, like a large ovarian cyst or other things that have been asymptomatic or gone undetected. So if you are having surgery, it's just a lot of pre and post-operative planning just needs to be done before you proceed with the surgery if you really actually need that. So that's the very detailed anesthetic consultation that they you know, make sure there's somebody available to you, that you have a pressurized mattress or somebody available to turn you every 2 hours after surgery so you don't end up with a pressure sore. Just, you know, some of that very simple, important stuff, and that you have a chance to come to rehab after and make sure that your bowel and bladder are working before you go home. So sometimes that can be done in the acute care hospital, or it can be done in rehab afterwards, but there just needs to be a little bit of a plan. And also some thought about what type of incision they're planning to do and how it might affect the rest of your care. So women have hysterectomy and do well, but I personally am a proponent of let's do the least invasive things first, and then if you do need surgery, then to proceed to surgery.
I appreciate the comment that you made about the pelvic floor weakness and dysfunction over time, and with women with spinal cord injury, and that has the potential to be further disrupted. It isn't until just very recently that I found a physician that is in agreement with that. I've been poo-pooed up until now on that, and I just am very leery because I've spent the last 10 years striking a very delicate, successful balance in my bowel and bladder function. So yeah, I appreciate that. Thank you for answering that question.
Yeah, and you will, some people as they age and they get pelvic floor atrophy, you will have your vagina prolapse down, or you can have your rectum prolapse down, or some combination of the two, which is confusing for people. And they can be repaired and pulled up if they need to be. So, you know, the pelvic floor literature and our ability to manage it is improving, but we have women living now 50, 60 years post-spinal cord injury experiencing some of these complications, and we don't have a big literature that guides us in the management. And hopefully that will come over time as we get more experience. I'm just saying there's a whole cohort of people now that are living much longer with spinal cord injury and having a relatively normal life expectancy, and then they're experiencing some of these complications with aging that in some ways we're crossing new territory. So it is worth talking to a few people and getting a couple of opinions before you make a big decision.
Excellent. Thank you so much.
Shannon, you've got your hand up. Go ahead.
Yes, I'm just wondering, how long do you generally expect the symptoms of menopause to last? In general.
It really depends. It's very, very individual. Like some people will have perimenopausal symptoms for a few months and other people will have it for a few years. And many people will have menopausal symptoms for, you know, about 2 years. Others are longer, some are less. It does ultimately change and cease, but if you look at the literature, there's a lot of variability. Yeah, I'm sorry, I don't have a really great answer for you.
No, that's fine. I was just looking for a ballpark. Wanting
ballpark 2 years, but for some people it's less. It's only 3 months or so, and other people it's a long time.
Yeah, I wish.
It's just like your period, you know, some people just fly through it, other people it's a drama.
Yeah.
Yeah, and it's sort of very individual.
Thank you.
Okay, there's no questions in the chat. I know we do have some people with lived experience, but we do have Dr. Craven, I think, until 4. So if there is any last minute questions that anyone has, if not, we will move on. I'll just, Lubna, go ahead.
Oh no, I was just applauding Dr. Craven.
Oh, that's okay.
That's okay. Well, thanks for having me in to talk about this, and I hope that you'll continue chatting. And if you have some good lesson learned or feedback for me about things that you think we could do better, I'd love to hear about it, because it's an issue where I think we need to do some work, both as a clinical and a research community, and make sure that we're meeting women's needs.
I don't know if you saw Dr. Craven, Sandra Mills is actually on this call as well. You had mentioned her name.
Oh. Yeah. Sandra, did you want to add anything? Did we lose her, or she can't unmute? I didn't even know she was here. Interesting. Sandra, are you able to connect?
I'm here, sorry. Sorry, doing 6 things at once. I don't necessarily have anything to add. I think that we are still in the process of doing our own little literature review here. And interestingly enough, I asked our librarian to do a search on menopause and spinal cord injury. And I said, look as far and wide as possible. And I think she got 6 articles. So there's not a lot out there. So we're all blazing ground together. And as we create this patient education handout, that will be very similar to the one that we did on managing your menses, it'll just be the same sort of thing. What is perimenopause, menopause? What are the signs, symptoms, things to look out for, and then any sort of treatment strategies. So we'll be coming back with the draft of that once we get through the launch of EPIC. I'll be able to turn my attention to that a little bit more formally. But Cathy, your presentation today has been a great framework, I think, to get the conversation going.
Okay, great. Thanks, Sandra.
Thanks, Sandra. Thank you so much, Dr. Craven. I really appreciate you taking the time to come on and chat with us and give us this information. It's helpful.
Okay, great.
Thank you.
Thanks.
So for those of you that are able to stick around, and Anita and Terry, are you still okay to stick around a bit to chat? Yeah, okay. Norma's going to go on next week's call. So Anita, if you want to go ahead and introduce yourself.
Sure. So those of you who don't know me, my name is Anita Kaiser. I just turned 50 in April, and I have a C6-7 complete spinal cord injury, and I was injured 25 years ago. And just in terms of where I'm at on that scale, I was perimenopausal for about 2 years, and I'd say I'm now fully menopausal because I haven't had my period in the last year.
Just a message from Sandra Mills saying happy belated birthday to you, and happy belated birthday from the rest of us as well. Could you tell us a little bit about why you think having conversations like this are important, and why you're participating today?
Yeah, so I mean, so it was 25 years ago that I had my injury, and I think I can say that at the time that I was injured, I feel like, I mean, we already know now, like Sandra just said, that there's only 6 articles on menopause. So I was only 24 at the time. So menopause was not on my radar. You know, I was more thinking pregnancy, parenting, you know, sexuality, women's health in general. And I didn't, you know, there was still not that much literature around on some of these topic areas. So I think it's just in general, it's really important to have these conversations just about women's health, sexuality, you know, periods, pregnancy, menopause, because, you know, we need to know it so that we need, you know, we can identify if there's issues occurring, preventative things that we need to do, if there's treatments that we can manage at home without having to see a doctor, also knowing when we need to see a doctor, and you know, when to recognize like symptoms as something that's important that needs to be found out. So I'm really glad that we're all here today to have this conversation. And you know, I learned a lot just, you know, through Dr. Craven's talk, and you know, even listening to some of the answers for some of the questions that others have heard. So even over the years, you know, it's been helpful for me to be able to speak to peers who've already gone through different experiences to learn from them.
Exactly. It's the power of peer, right? That's kind of, it's a big one. So could you tell us a little bit about your symptoms and how you've managed them personally?
Yeah, so I started writing, I was writing some of them down to just get an idea. And it's odd because, so I went through a health issue for about a year just prior to COVID, and then COVID hit. And so my transition through pre to perimenopause to menopause has occurred over this whole time frame. So I think it's very, very hard for me to be able to delineate, you know, what symptoms I could directly relate and connect to menopause versus COVID and being home and less active, and then also like other health issues. But you know, some of the things that I experienced was, let me just go through. So I had a fracture, and I know that my bone density declined from one year to the next significantly, whereas I was on like a regular, you know, medication treatment for bone, and it had been working in, and I was for a while getting slight improvements over the years. And then, you know, COVID hit, I stopped exercising, stopped weight bearing. So, and then going through perimenopause. So really, like I said, hard to say whether it's due to that, whether it's a combination of that and menopause that I experienced this bone loss, and then, you know, a resultant fracture as a result of it. But I've changed my bone treatment plan now to something that's a bit stronger to compensate for it. So that was one thing. I've noticed a lot of digestive and bowel issues. And it's not that I didn't have issues prior, but I feel like it's definitely increased. A lot of food sensitivity that's become much more pronounced now. Again, I don't know if there's a connection or not. I'm really curious to hear what others say, if they've noticed any changes with their bowels and digestion after menopause. That would be really, you know, interesting for me to hear. The sleep quality has definitely been an issue. I experienced night sweats for a few months, not consistently every day, but several days out of a week, and just really like fully drenched. And as Dr. Craven said, I automatically thought it was AD, tried to figure out what was going on, often assumed it was related to positioning in bed. What's interesting is I switched, didn't switch my position, but I ended up putting a pillow between my thighs, which I never used to do when I slept sideways, and it disappeared. And I haven't had it since. So it really makes me wonder whether it was just a positioning thing, but I couldn't really figure out any other cause for it. And it didn't seem to, like when I tried to change positions, it never really went away. So that was, again, something interesting. I find I'm much more susceptible to temperature. And I've always, as a quadriplegic, always been cold, but I find like it's 26 degrees today and I'm wearing 3 layers with a turtleneck. It's ridiculous. I have my window open. I'm sure if I go outside, then I'll feel hot, but inside I'm feeling perfectly comfortable now. But I have a space heater on my desk, and it's usually often on when I'm in my office. So definitely feeling that more often. I find my skin is more sensitive. I often see like little brown, like the little brown bruise dots where, so I bruise much more easily, and I find I have to be more careful, like with pressure sore skin lesions, like with my heels, which I never used to have an issue with before, and just other areas. So I just have to be really careful with that. Concentration. I find when I'm working, I have to take a lot of micro breaks while I work, because I, you know, my concentration, I can't hold it for as long. And I find I get a lot of mental fatigue. So I have to really, my work day gets extended because I have to break it up with breaks. The functional decline that I've had, which I'm going to assume is related to COVID, not exercising, but I've definitely noticed that. And anxiety, you know, it's interesting. Dr. Craven brought up the whole mood thing, never really related to it. But now that I think about it, my mom had also told me about how my grandmother, definitely as she got older, started to get a lot more anxiety and worry. And I can really see it in my mom that she becomes very anxious and gets really worried and worked up over things. And I can start to feel myself getting that as well, where you start like thinking, you know, the worst situations and the worst scenarios that are going to happen and something that might not even happen, but you start worrying about the what ifs a lot more and getting really sort of anxious about things. So I start to notice that.
I think it's got to be, as you said, very difficult to know what is menopause or perimenopause and what is just a buildup over time if we're just exhausted from multitasking for so long or having to concentrate so hard that regardless, do we just hit a breaking point or is it related to menopause? Certainly. What supports have you accessed on this topic, or who have you talked to that you felt has been helpful?
Yeah, so surprisingly, I haven't talked to any peers. I think because I'm still really new through this, and I don't know, I don't know why, but I haven't really talked to any peers, and I have developed a fairly good close network of women that I think we're all close in age that they would be great to feed off of, because they're definitely the ones that I spoke to when I was talking about parenting and breastfeeding and that sort of thing. But I didn't really think to seek out, information from people, but hey, have you, experienced this or that or whatever. So really it's just been my family doctor and my physiatrist that I've really spoken to say, this is what's going on, and, am I in perimenopause or menopause, and, getting your hormones tested to kind of get a sense of where you're at.
And what would you want a newly injured person to know about the topic of perimenopause or menopause?
So I think it's basically really what I've already said. I think like the presentation that Dr. Craven was great, because you just kind of want to know that basic information of like what to expect. I think going in knowing that, you would actually have it more at the forefront of your mind and be able to maybe make those connections. Whereas, I didn't really do that. And I was, kind of piecing it with other things, which, like I said, it could be. It's hard to make those, it's hard to know for sure what's the cause is, but knowing that ahead of time, and then knowing also what are risk factors that you need to be aware of and keep your eye out for, and then trying to be preventative. One of the things that Dr. Craven was bringing up too is like about mammograms. So I'm going for my first mammogram tomorrow. And I can tell you, it took a while to get the appointment scheduled and it was at a hospital because there's no other places to go to for it. But the hospital wasn't accessible originally. And they've now made accommodations by, they're gonna bring in a transportable Hoyer lift from, I think, another department somewhere to the unit, and make sure that they have extra staff available that day so that they can help me onto the machine. So, if it was the day after, I could have told you guys how it went, but right now, I'm just going to cross my fingers and we'll see how it goes.
Well, perhaps if you can join us next week, even for a little bit, you can give us an update on how that went.
Okay. Yeah. I'll see what I can do. Yeah.
Super. Thank you so much, Anita.
Yeah. And sorry, I was just going to say too, it's really unfortunate that Lyndhurst used to have a wonderful gynecology clinic where we could all go to. Unfortunately, that's shut down now. So myself, along with, I'm sure many other women, like we haven't had our gynecology testing done since then. And I have my family doctor kind of like on the hunt to find a place where I can go to. Likely it'll be a hospital as well that will be able to accommodate me for that. So I think that's the issue. But yeah, I think for someone new, it's really just getting that basic information of what to look for and what to try to prevent. And then if you have things like how to treat it and when to go see a doctor, really, I think that's the important things.
And connecting with peers, would you make that recommendation as well to build that support where you can speak with one another and share your experiences?
Yeah, like I said, I'd love to hear if others have had any of the same symptoms that I've experienced.
Yeah, super. I see Julie has her hand up. Julie, do you have a question for Anita?
Anita, thanks for sharing your symptoms, because lately I've been having night sweats that I was thinking was full bladder, right, in the middle of the night. And because I had a uterine ablation done, I don't have my period, so I don't know where I'm at. And I kind of feel like I'm flying in the dark with this, being that I'm 48, right? So I guess if I were to go to my doctor and say, can we test my blood levels for my hormones, I have a feeling that he would say, what do you need to know that for? What do I say to him?
I would simply just say that I think I'm going through menopause, and can I get a check to see? Because I know, like, Dr. Craven's my physiatrist, and that's one of the first things she did is have me go for blood work. Her, or even my family doctor did it as well. Have me go for blood work so they can check. And I don't know exactly, or I don't recall which hormones it is that they're checking for, but they'll be able to check the levels, and from that they'll be able to determine at what point in the cycle you're at, you know, if it's perimenopause or full menopause.
Because I think he would say, well, what are you going to do about it? It's like, it's going to happen anyways, because he's said that about other things. And I'm like, I don't have a response for that. Anyway,
is that your family doctor, Julie? Is that what
yes.
you're saying?
Yes.
So would it be the path of least resistance to see your physiatrist about that then, rather than trying to deal with somebody who you know might not be communicative?
Yes, that's probably a really good idea. Yeah, thank you. And side note, like, you guys that are in Toronto and can't get appointments on an adjustable bed, that blows my mind. Or a mammogram that's not accessible, because I live in like middle of nowhere, southwestern Ontario, and my little community hospitals have facilities that are accessible. So I'm so confused. Anyways, it sucks.
Yeah. I know that when I live in a small town too, when I went in for my mammogram, I was asking specifically if somebody came in with mobility issues, how would you handle it? Expecting a very, well, we're not equipped. And, oh, they have it all figured out. And they have a machine that goes all the way down, and this is what they do. So that's so confusing that Toronto, being such a big center, wouldn't have that. It is, it is, it's probably tip of the iceberg of what's can boggle the mind of what's available and what's not, right?
Yes.
Margaret, I see that you have your hand up.
I'm just itching. So I started going through a lot of this transition in my late 30s. And I'll be honest, I felt quite a lot of shame in even disclosing that to anybody. So I hid it for quite a long time. All I noticed was that I didn't feel like myself anymore. I didn't know why I felt sad or mad, and these are the range: suspicious, foggy headed, without any real indicator. And I was able to confide in a younger aunt and ask, what her experience had been. And she did indicate that she went through perimenopause and menopause early. And so I started asking my primary care physician, and then my physiatrist also asked me a little question about it, because I was having what he thought was premenstrual dysmorphic disorder, which I actually think all women get heavy duty effing PMS, but just don't say anything. And then they decide to tell women that they have some extra PMS. But my doctor, my family physician, did the very same thing to me as what you are describing you're afraid will happen to you. Oh, you're too young. Oh, why would we need to look at your hormone levels? And I think my suggestion would be either ask for a referral to a gynecologist, or, and I'm sure I'm in Alberta, but I'm sure something similar exists near you. Find a little bit of extra cash and go to a private clinic that does look at hormone levels for women privately, and get that information for yourself. If you ever spend money on discretionary items like clothing or going out for dinner, this is more worth it than those things. And I felt so validated when I went for that first set of appointments that I paid for out of my own pocket. And I was able to take that information back to my GP, who then was somewhat apologetic, mostly because, and these were his words, I just feel bad that I couldn't be the one that helped you. And I don't really care what makes him feel bad. All I care about is whether or not I'm going to get some service from my medical professionals in my life. And since then, it's interesting. Things have come along, and people who help in the area of women's health are much broader in their applying a lens to women at various stages with various different presenting symptoms that are impacted by hormone levels. And I just think it's so devaluing to be dismissed and told to wait it out. Because there are very many things that can be happening to you during perimenopause that are easily treatable and can ease your discomfort or your experience of those symptoms. And I just, that's me, and I'm going to jump off the soapbox.
Thanks, Margaret. Norma, you had a question?
Yes. No, I was just going to say about the blood work hormone testing. You could ask your doctor that you want to get it tested so that you have a baseline, so that you know what it's at, so that if you get it tested 2 years from now, you'll know if it's gone down or whatever. My family doctor, he was kind of iffy at the beginning, and then he was like, well, yeah, okay, we'll do a baseline. And like, I have had tests, and like the last time I had it, which was a couple of years ago, I think, or a year or more ago, he was like, you're definitely, you know, in menopause. Like, so I think if you just kind of word it differently, maybe, or do it so that you have a baseline, that they may be more apt to do what you want. Also, I was going to say, I'm in Hamilton, and my doctor can't do a pap smear as well because of his big metal desk thing that he has in his office. So I had them, it took a while, probably over a year, for them to find me a gynecologist that I could go to. And she is in Hamilton, and she's at St. Joe's Hospital. And she's wonderful. And she has 2 different rooms with tables that go up and down. So I can just transfer onto the table and she puts it up. But she mentioned to me that she does a, I think she does it once or twice a year, where she'll do a clinic that is just for women like us that have all different mobility issues, that need help getting onto the table or whatever. And she does these clinics. So I don't know if where you live, maybe it's just need to do some research or get somebody to phone to find out these things, because maybe there is something being done where you live, but you just don't know about it.
Thanks, Norma. Okay, so we've got another individual, Terry, if everyone is still okay to stick. I'm good to not go. Oh, if everyone's okay to stick around just for a few more minutes, Terry, if you're okay to just introduce yourself and give us a little synopsis about your experience.
Sure. Thank you, Anita. Sorry.
I'll try to be really quick because I know it's getting late for everybody. But so I'm Terry Thorson. I'm actually here in BC. And I am very similar to Anita, actually. I didn't realize how close we were, Anita. But I am turning 50 in July. Also had 26 years in. So I got injured. I'm in my 26th year. I got injured also when I was 24. And I'm also C6 complete myself. So yeah, there you go.
I was going to say you're my either twin, because I actually have an identical twin. So you're like my other one, my guy twin.
It's triplets. Terry, could you tell us a little bit about why you think these conversations are important, and why you participate so willingly in so many of these types of conversations?
Yeah, so I think probably it's really just because we got to get the conversation out there, right? I mean, in my search, I think everyone has different, we're all trying to figure it out. There obviously is not enough information out there for us to be able to find. So if we can just connect with one another a little bit more, I think then we can start to normalize what we're going through instead of trying to just figure it out on our own or with people who don't really understand spinal cord injury.
So could you speak a little bit about where you are at right now, or what kind of symptoms or what you've experienced?
Mm-hmm. So I am apparently perimenopausal, and I guess have been for a couple years. I started noticing my periods, I mean, I've always had irregular menstruation, but it has become even more so. Like, it's just, who knows what's going to happen every few months. Sometimes I get a couple periods a month. Also, the consistency of the blood has changed quite a bit. That was very dramatic, seeing like it much darker and kind of those clots, which I never noticed before. So that kind of freaked me out in the beginning. And I started also noticing like my mood changed quite a bit. So I started really hating people, which is really not within like my personality. And it was pretty miserable, I'm sure, for my partner and my son at home. And then obviously I've got all the very similar symptoms to what Anita was talking about. So I was noticing sweating at night in particular when I was sleeping. So also wasn't sure if it was AD or not. I'm sure I go through hot flashes. Like, you can probably see my face is like really red right now. And I'm wearing my sweater. So I'll wear my sweater in the morning, and then in the afternoon, I'm usually like, oh my God, I'm dying. I need to go outside, which is also not very like myself. I'm a very inside kind of person, but need like air and fresh air. And I need sometimes people to actually roll the windows down in the car, which normally I have it at 30 degrees and everyone's dying. So those are kind of some. I noticed my spasticity increasing. And I was getting like quite sweaty when I got AD. So specifically when my bladder was full, which I never had before. So I think I attribute that to perimenopause as well. Is I would just sweat like crazy. Like, I actually have to wear deodorant now, not so much anymore because I'm managing it. I'm on birth control pills, and so that's managed quite a lot of my symptoms. I really have no desire whatsoever. I have no sexual desire, and I'm still working on that. Like, it became a point where it actually grossed me out. So that thankfully is better, but still it's not like, now I'm not asking for it. I just feel like I'm flatlined at this point. So I still have a long way to go, I think, but I also think and recognize that there's probably many changes to come along the way.
Thank you so much for sharing that, Terry. T. Walsh, I see you have your hand up.
Sorry, I had to unmute myself. I'm late to joining the conversation, and I apologize. I missed probably a lot of really good stuff. This year I'm 39 years into my injury. I got injured when I was 16 in '83, and I thought things were coming a long way for us. Dr. Graham, who was at Lyndhurst, I don't know if any of you ladies had seen Dr. Graham, who lived in the GTA. She was just an awesome gynecologist, and she was really great. I'm 55. I'm assuming I'm into menopause now because I haven't been to a gynecologist in I don't know how long, which is concerning. A lot of bad information first went out. When I first got injured, there was no information on SCIs and pregnancy or child rearing or anything. That actually stopped me from deciding to have kids because nobody knew anything. And then with all the HPV and the cervical cancer and uterine cancer and cancer runs in my family, I'm stuck too. I don't have anywhere to go. My doctor looks at me when I told him that I wanted to get my hormones checked. He said, "You're just in menopause." And I said, "No, you don't seem to understand. I'm a spinal cord injury. My body wreaks havoc on me. So I'm at the age for premenopausal, and now I'm menopausal, I believe, but he still won't send me to get my hormones checked because I'm going through menopause. There's no ands, ifs, or buts. And I just don't get that thinking. We're all kind of in the same boat.
It doesn't make any sense to make that comment and not, it basically it's saying you shouldn't be concerned, you shouldn't be having a conversation about it. And why are people being silenced from having these conversations? Is it because they're just not equipped to have those conversations themselves? They don't have the information, and sometimes ego gets in the way because they can't say, I don't know. And let me send you or connect you with somebody who might know. Sorry to jump in on that, Terry.
That's okay.
I don't know if you had anything to add to that, Terry.
Yeah, I was just gonna say, oh, sorry, I'm Terry too, Teresa.
I'm Tammy.
Okay. There you go. No, I was just gonna add that, like in my case, no one's actually, so what I've learned about menopause is that this is what I was told. I hope it's accurate information that I'm providing today, but that they will consider you in menopause if you have gone a year without your period. Yeah. So I haven't gone through that yet, but they haven't done any blood work for me or anything. And now I have a very good healthcare team, and they're very knowledgeable about spinal cord injury. And it's my partner's, like, he is just losing his mind because he's like, why don't you just get a blood? Like, why don't they just confirm it? Well, I go in there, I tell them all my symptoms, and they're like, well, this is what's happening to you, and these are what your options are, right? Like, why do you need to confirm it? I don't know. I don't know if that would be good, but I can tell you what I've been trying right now has been helping me. And I know that there's lots of different options to be able to try. So maybe it's just a matter of, like, you know, finding the right people. And if you feel really strongly about getting tested, then find the right person who's going to say, yes, you should be tested.
Well, needless to say, he's not my doctor anymore.
Oh yeah, exactly. Yeah.
Yeah. I don't think he appreciated the fact that I wouldn't back down. I stood my ground for a lot of things because I have found that throughout the years, women's health is not on the forefront. It's somewhat left behind. If you don't, excuse me for saying this, if you don't have a penis, you kind of don't count. And then when Lyndhurst brought in the gynecologist, it was unbelievable. It was like the best thing that ever had happened to women with spinal cord injuries. And now that Dr. Graham's gone and we don't have that gynecologist at Lyndhurst, excuse the expression, we're all kind of screwed. So, and it's not fair. I mean, we have a lot to deal with to begin with, being in a chair, and now it's just gotten worse. So, but that's my opinion.
We have 2 more people with their hands up, and we also have a comment here in the chat. It says, I have had a blood test and it showed a bit of irregularity, but nothing conclusive. From what I understand, the hormones change so much that hitting it at the moment where it looks perimenopausal isn't easy. Yeah, but I think to have as many, you know, I think we should be listened to. If people have questions about their health, we shouldn't be shut down regardless of yeah. Julie, you have your hand up.
Just a quick question. So Terry and Anita, you both have mentioned sweating. So I've got a C4-5 injury and I don't sweat. So when you say sweating, are you actually like perspiration sweating, or is it different?
So I'll start here and then you can add in. So I'd say it's predominantly above level injury. But I have noticed maybe my legs feeling damp as well, although I don't know if it's just from lying maybe on that one side, but it's dripping. It's not just like sweating. Like it's like I will get up, my top, you can almost wring it. There's like you can see, like if it's like a dark colored bed sheet, like it's like this, it's like drenched. Like I have to like change the sheets. It's profusely sweating, but I can profusely sweat too when I'm getting severe AD symptoms. And it's really hard for me to know and figure out because I'll usually also feel an elevated blood pressure. Like I'm very good at sensing my blood pressure if it goes up even just minimally. And I feel like it did, but I don't recall because I've stopped sweating now several months. It's been at least several months. And it was, like I said, it was this night and day difference, just like adding a pillow between my legs. And So it really makes me like, I almost feel like, let's take the pillow out and see if I get it. But I really don't want to deal with like sweating overnight again. So like, I don't want to rock the boat. It's been working, and like, just leave it. But yeah, otherwise I don't know if it was like the real night sweat. I never got the flushing that, Terry. And honestly, I was like, same with pregnancy. I'm like, oh my God, finally, for once, I won't be cold anymore. And it never happened. I was like, I'm like, I've been through pregnancy and I didn't even get a hot flash. And menopause, nope, I'm still cold.
Yeah, for myself, it was similar to Anita. So at night it was, well, I am, I have been dripping. I don't anymore because of the birth control pills. But yes, so before I took them, I was dripping at night. I thought it was AD as well, but I've never been dripping with AD. I usually get like that clamminess, kind of stickiness feeling. This was literally, I have like sweat stains underneath my armpits, and wringing out shirts and changing bed sheets. And I have noticed that I really have sweaty crotch now. That is where I sweat a lot too. So there's a lot of, yeah, obviously, but I haven't noticed my legs, like my legs aren't, but just in my crotch area.
Thank you.
Thanks for that. What kind of supports have you accessed on this topic, Terry, or who has been your support of the people you've been talking to?
So as I mentioned, I have a really good healthcare team. So I see my physiatrist who, interestingly enough, was also an OBGYN before he was a physiatrist. So that's really helpful. We have an amazing sex team here. And I think one of your guests next week was supposed to be she is my OBGYN. So I have a great, amazing team. And they've all helped, but we have yet to find a solution, right? It's an ongoing process. So
did you want to tell people a little bit about the Access Clinics? I think it's interesting because we have multiple provinces here, and so we're getting very different access to different healthcare, right? So can you tell people a little bit about the Access Clinic and what makes that amazing?
Yeah, so the Access Clinic is a place, it's at Women's Hospital in Vancouver, and it's a specific clinic. They'll do mammography. There's a whole bunch of different things, breast exams, PAPs, but it's a fully accessible, and the nurses and clinicians there know about disability. So many different people go there with different disabilities, not just spinal cord injury, but especially if you have like spasticity issues, they're really great about dealing with that. A lot of women, some can't even like open their legs to get a pap smear done, right? Because their spasticity is so long, especially those with cerebral palsy. So they're really great. They also ask amazing questions to prepare you in advance, which I've never had before. And they also tell you everything that they're doing, which is really great as someone who doesn't feel anything. It was really interesting when I got there and they're like, okay, I'm now going to touch you here. Now I'm going to insert the speculum, and, and telling me every process along the way, which I really, really appreciated. And I think that's by Megs. Great. Yeah. So they're an amazing clinic, and I think it's the only one across Canada. Many people in BC travel just specifically. I mean, it's really sad that we have to do this, but they have to travel to come to Vancouver from the interior, from the island, just to get a pap smear, right? It's horrible.
I think it would be great if other areas in BC could use that Access Clinic as a prototype, to maybe consider how we can move forward. And as well then for provinces like Ontario, and I know we have Alberta represented here today too, that if they're looking to do something, that could be a model for how things could maybe be done, because I know they also are very helpful for people who have been through trauma as well. So it's the way that the Access Clinic works is it's very inclusive, isn't it, as far as what they're looking at? Yeah. Thanks, Terry.
Okay, well, thank you so much for staying. Is there any last minute questions or stories or anything that anyone wants to ask one of our
I just have a comment.
Yeah.
I know that both Anita and Terry mentioned that they're going through menopause right now, and it's a process, and I understand. Do you really have to remedy the lack of sexual desires? Because if you don't feel like it, can you just ignore the act altogether and wait for your urges to naturally return if they do?
Well, that's what I've been doing, but it doesn't work so well in my relationship. You can ask my partner.
More convenient for me not to have. Yeah, it would be so much more convenient if an intervention was not required, though. So,
yeah, I think that I wonder. Have you had conversations with your partner, Terry, about that, so that at least you both are on the same page with where you are at? And
we have many conversations about it. He is maybe not as patient. He's a different personality than I am. And I think like he feels that I'm not working on it enough to his liking, that I need to be a little bit more working on it. I think it's a bit of it's a whole thing. It's mind and body, right? And I'm not there yet. He's very supportive, but it's hard. It's been a real toll, and positioning has been something that I'm going in for actually to physio and OT to work on different positioning, because I've also had a lot of pain. And so that has been really playing with my mind, like AD has increased during intercourse. And yeah, it's just it's a whole like changing behavior, him changing behavior, that sex is more than just sticking a penis in a vagina, right? So we both have to work on it together, I think. Anyways, sorry, Anita, you go ahead.
No, I was just gonna say, so I think I am officially menopausal because I haven't, it's literally like almost, I'm right at the 1 year mark where I haven't had a period. So I think I'm now officially at that point. My husband is 6 years older than me. And so I guess I'm lucky that he kind of lost interest before I did. And I was like kind of flatlined. So I was, it was no problem. And I was gonna say, I think it's just really individual between the couples, like, and you just gotta deal with it at that time. And if it's an issue for the one couple, then they need to address it in the way that works the best for them, and if they need to seek assistance through counselors or medical professionals to help them work through and come to an amicable resolution about do that. I think that's to them.
Yeah, it is very individual, isn't it? So definitely it can't be a one size fits all. But I think definitely having that communication piece in there is really important between the people in the relationship, and then whether or not, as you said, Anita, bring somebody else into it, like a therapist or something, if that's needed. And it could be that, yeah, in that conversation, it's decided that maybe that kind of sex is maybe done, and maybe it's something new, or maybe just continuing to have that conversation that you do come back together once again in a similar fashion. So, yeah,
and I just want to emphasize the point that Terry made. There's so much more to sex than just penetration, and so I feel like it does not get the attention that it deserves. And I think a lot of people recognize and realize it once they have a spinal cord injury. They recognize all the other options that are available, and I think maybe that's something that needs to be re-explored again.
Thank you, Anita.
Lisa, you have your hand up?
it's so interesting. I have really been exploring this from the autistic perspective because that was a diagnosis that I received late in life. And I was like, whoa, what is all this going on? And my counselor was like, you're probably going through perimenopause. And so I started to think about like all of the things like overstimulation and whatever, and hearing everyone talk about pain and these mood changes and lack of sex drive is extremely interesting because I'm an incomplete spinal cord injury. So I have quite a bit of feeling, quite a bit of function, but it's not normal. Like it's not typical of an able-bodied person. And so the pain that I started to experience was indistinguishable to me, which I had never had before below my injury. I always was like, oh yeah, I can tell what that is that hurts. And it is emotionally connected for sure during sex. And also it is, it's hormonal. Like, so it depends on where I am in my cycle, whether it just shows up. And I've noticed this with all of the symptoms that are also common to like other comorbidities, that there's a certain flavor of it that is hormonal when it happens, right? Like there's a certain flavor of rumination that is hormonal. And then there's another flavor that is like my OCD autistic side. And I'm like learning to push those into their little boxes. So I am like super grateful to hear all of these experiences, but also I feel that same feeling of like when, and my partner's younger than me, which was stupid. What was I thinking? But like, I actually started doing this thing where I said, okay, here's how sex is going to work. These are sex levels for me. And like level 1 is like kissing on the mouth. Level 2 is you're kissing me other places. Level 3 is your hands are on my body. Level 4, your hands are on like the sexual areas of my body. And like, there's like several levels, like 12. And I really thought this was an autistic thing. But I told him that every time he's going to change levels, he has to ask for my enthusiastic consent. And so I have to feel comfortable enough to be like, I'm not ready yet. Like I'm excited, but I'm not ready yet. And when we started using this little method that I had created, I had never felt so in control of my body during a sexual experience with a man, because I'm bisexual, than ever in my life. And so I have sort of used that in a way, but there is still this side of things where sex always ends up being about penetration. And I'm like, fucking dudes, like, I only have so much room for penises in my life sometimes. So, but yeah, so I hope that we can continue this conversation somehow because it's so validating to hear. So thank you.
Lisa, I would love to, I just put my email address into the chat. I think the fact that you have basically body mapped to say, here are my 12 steps, and first of all, your communication is incredibly clear with the partners that you're with, which is really important. I would love to chat with you, and if we could do some sort of like an interview and a recording that we could then share with people, I think that would be brilliant because you've nailed something there. And I think it's really important. And from a personal point of view, my partner has a spinal cord injury. So it's never been about penis vagina because there is certainly way more. There's lots of options there. And I think certainly having those conversations is really, really important. So thank you. So please, if you're up for it to reach out so we could have that conversation, that would be super.
I will.
No, Ashley, you know what? Sandra needs your 12 steps and put it in a brochure.
Exactly, right? Exactly.
Sandra, if you're listening and you get the recording.
Yes, I told her I would send it to her, Anita, because that's exactly right. I think as many of these conversations as possible, like Dr. Craven said, there's so little research out there, right? So if we can gather these stories and it be a starting place, and it could also be showing the people who are willing to share their stories and be a part of maybe a study or something like that, I think would be really great, eh?
And Lisa, to let her know if you saw that we do have another session next week as well on Wednesday from 4 to 5. So that one I think is going to be at this point, all individuals with lived experience that are just going to share. So kind of like this, right? Just sharing stories and hopefully getting conversation going. So if you haven't signed up for it and you're around, that's next Wednesday from 4 to 5. Mm-hmm.
Eastern Standard Time.
Eastern.
I already registered.
Oh, good. Okay. Thanks, Mel.
Oh,
and
Julie,
you know,
this is for you. One last thing about sweating. I forgot to mention, it is really stinky sweat for me, which I never noticed before. I never had stinky sweat, but now it's super stinky.
All the things to look forward to.
No.
Well, this is great for me too, because I'm 43. So I'm, kind of heading into that territory. So for somebody, that's going to start to be there soon, having this information is absolutely amazing. And I thank you all for how open and honest and how much you're willing to share, because, as Dr. Craven even said, it can be awkward conversations having to talk about this stuff. But I think it's amazing when we can all be open, because we're all going to go through something similar. So the more we can share, the better. So again, I thank you for your openness and your willingness to come on these kind of talks and take your own time to do that. So thank you for everyone that's been here. Thank you to Terry and Anita and Margaret and everyone else, Dr. Craven, that's been on and shared their stories. Thank you, Melanie, for all the help, for being my co-host, for all the help that you've given me. And Melanie did put her, the T6 Talk, sorry, Melanie, T6talk.com is the website?
Yeah, t6talk.com is our website. So we do have the period page. So when I get the recording of this session, I'll post it on the website, and then I can forward it to Julie as well, so that she can send that out to everybody. And if people are interested in chatting and recording or doing some, they're not interviews, it's more just casual conversations. If you want to share your experiences and do that one-on-one, I'm happy to do that too. That would be great. So yeah, and I put our email address in the chat as well.
Awesome. So just a very quick shout out to our sponsors. So we've got provincial partners, the Insurance Bureau of Canada and Hollister Inc., who is our provincial bowel and bladder, as well as vehicle modification sponsors. And we've got regional sponsors, Learners LLP and Mackenzie Lake Lawyers as well. Again, thank you all for your time. Please join us next week if you can for more of this amazing, great conversation, and have a nice evening.
Yeah,
enjoy the
thank you.
sunshine
Bye,
if it's
everybody.
warm and sunny.
Thanks, everyone. It's been great.
Yep. Thanks.
That went well.
Is that okay that we're 45 minutes over time?
Yeah, I think it's amazing.
Can you guys wait?